Hello, hello, everyone. Thank you so much for coming. Happy New Year. This is actually the first webinar of the new year for Nashua. Just getting everything set up, letting folks get on the call. Again, welcome. Thank you so much for coming. We appreciate you guys taking the time out to come and spend with us today. Okay, let's get started. So thank you all for coming. My name is Aurora Grant Wingate, and I work for the National Association of Community Health Workers as their Member Partner Engagement Associate, and I'm going to be emceeing our webinar today. This is our first annual webinar around the National Day of Racial Healing, which I'll talk a little bit more about in a minute. And we're excited to have Romana and Abdul here, who are co-chairs of the APHA CHW section, to talk about new policy work they are doing around CHWs being racial justice advocates. So we will get started. For those of you who might be new to Nashua, firstly, welcome. Thanks for joining our webinar. Basically, to give an elevator pitch on our organization, we're a young organization, almost 4 years old now. We are a national member association for community health workers. We have over 2,300 members across all 50 states. And really, we were founded to execute a shared vision of seeing community health workers united nationally to support communities in achieving health, equity, and social justice. And again, this is just to visualize some of our membership and the reach and impact that we seek to have. We'd love to start off today by we're trying out a new way to do an icebreaker in these webinars. It's something called Mentimeter. Folks can either hold this up to your phone and vote that way, or I'm going to share a link in the chat to answer the question of what are 3 words that you associate with being a community health worker. So give me 1 second to throw that in the chat. Oops, that's not quite right. There we go. If folks can click on that link, or if you want to throw it in the chat, what are 3 words do you associate with a community health worker? Oh, and we can see the results start to come in. You can see folks are throwing in, oh, thank you so much for answering it, empathetic, community, passionate, hard work and empathy, relationships, that's great, non-judgmental, empathetic. Oh, I see friendship, an advocate, compassionate. Oh, this is great. The results are pouring in. Community, relationships. Yes to all of these. This is great. In service of others, an agent of change, a lifesaver with resiliency, a trusted community member. This is all really fantastic. A humanitarian, lived experience, dedicated, a community champion. Yes to all of this and more. This is fantastic. Thank you guys so much for participating. I think we've had 22 people participate already. And now I'm going to share, we have one more for us today, which is, what words do you associate with racial justice? So think on that for a moment, and I'm going to drop that in the chat as well. So you can go to that link and I'll bring that up. Oh, I saw someone drop in the chat, freedom. That's a great one. So I know freedom was one folks started to share. And as folks start voting, they'll start popping up on this screen. When I say other folks are putting in the chat, eliminating barriers and confronting the status quo, obstacles, advocate. Someone put here atonement, forgiven and fairness, reparations, liberation, change. These are all fantastic. I'll give it another minute for folks to get their thoughts down. See, fairness is coming up. Words that are bigger are words that folks are putting in more than once. So we have inclusion, equity, freedom, change, co-advocatators. That's a great one. We have love up there. That's great. I'll give it one more minute for folks to jot down their thoughts. Equality, inclusion, the world we want to live, absolutely. Equitable access, that's fantastic. Reparations, change. This is all fantastic. Thanks, folks, for going along. This is a new thing we're trying to get folks' thought down on the topics. So thank you, folks, for participating. I'm gonna switch back to the slides for a minute here. And I just want to talk a little bit about what is the National Day of Healing and why it matters. This is actually something that was started several years ago by the Kellogg Foundation. It was launched in 2017, and the National Day of Racial Healing is a call to action for racial healing for all people. It originated as part of W.K. Kellogg's Foundation's National Truth, Racial Healing, and Transformation efforts. And just to give folks a sense of what the point of this day is, I want to read a paragraph that's on their website, which says, racism affects all of us regardless of our backgrounds or circumstances. We all live in a world born from historic racial inequities that have led to broken systems and division, where we don't know one another in our shared history. These significant challenges will not be solved by one individual or group. To ensure our communities are free of systematic racism, we must come together to explore how past actions have created present racial inequities in our systems. Our goal is to create equitable cities where everyone thrives, including people of color, by helping cities, towns, and villages build their internal skills and capacity to apply racial equity to their policies, practices, and procedures. And this responsibility belongs to all of us to participate in these honest, powerful, and moving experiences and pursue this racial healing journey together. So that's what we wanted to come together and do with this webinar today. Before I hand it over to our speakers, I just want to run through a couple of different resources on our website for folks who are interested in learning a little bit about what NACHWA has already done in the space around racial justice and CHW's roles. This is a blog that our executive director, Denise Smith, wrote several years ago, actually, again, for Martin Luther King Day, around what she titles The Forgotten Healers, which goes into the history of enslaved Black Americans and the long history of community health work in those communities. It's a beautiful blog. I'll drop it in the chat. And another way to learn a little bit about the history of community health workers. Throughout our short history as an organization, we have also been doing work specifically around the pandemic, around funding streams, and really targeting the racism that can be baked into these funding streams and how to improve that to create further sustainability. We also have some new national data on the ways that community health workers are able to be racial advocates and do racial equity work in the workplace. Again, you can find this on our website, and I'll drop this in the chat. And this is sponsored by Johnson & Johnson and our Racial Health Equity. And lastly, since again, this is the day of racial healing, we want to really acknowledge the importance of mental health and self-care for community health workers, which is a profession we know is a majority people of color. And we want to make sure that we're acknowledging how these two are intimately linked, especially in this in this moment that is also a mental health crisis. So we will continue to be working on creating resources and trainings for community health workers to respond both to themselves and to their communities. And with that, I'm very excited to get to hand it over to our speakers for today, Rumana and Abdullah, who are going to walk us through some of their work through the APHA CHW section and the role CHWs can play as racial health advocates. So Rumana, I will pass it over to you. Thank you so much for being here today.
Thank you so much, Aurora. Can you hear me okay? Okay, great. That's good. So I'm going to go ahead and share our slides so you all can see that. Hopefully you can see it. Let's see. Okay. Yeah, so today Abdullah and I are going to talk about a policy that just got passed in November. Some of you from our policy committee are here. Angie, who's also one of our co-chairs. NATRA has been a great support. So I want to thank you guys. It's called A Strategy to Address Systemic Racism and Violence with Public Health Priorities, Training and Supporting Community Health Workers to Advance Equity and Violence Prevention. So we wanted to give kind of just a brief overview about CHASM. The policy is from APHA CHW section, but the principal authors, which are myself and Abdullah, are from CHASM. So we're going to talk about the work we've done, which are case examples within the policy, as well as kind of give you an overview of what we've been doing. So we're a community-led organization of strategic learning that aims to build capacity for community health workers and community-based organizations, i.e. community assets, within historically oppressed communities, neutralize systemic inequities, and enhance harmony within the social ecology. We recognize the deep chasm between European, non-European ethnic communities in American society, communities and institutional organizations, and healthcare and social determinants of health interventions, resulting in the perpetuation of violence and inequities in our system. So violence is just as important as racial inequities, which are connected, and we'll talk about that more. I'm the Director of Strategic Improvement and Policy. Abdullah is the Director of Programs and Community Mobilization. Our collaboration is based on lived experience. Lived and shared experience elevated by community of solution skills, the merger between systems and the academy and the community. And the foundational framework that we use is community assets and CHWs, working across the sociological model to address structural and social determinants of health. And we'll go ahead and go into the problem that we have first, which Abdullah will go into.
So cool. Good afternoon, everybody. Again, it's always a pleasure to be able to share with passionate and dedicated people to be able to actually try to make humanity a little bit better. In order to look at the problem, one of the things we want to first highlight is some language that was outlined inside of our policy, which was really designed to be able to help us all collectively support making sure we don't continue a legacy of colonization. And one of the issues that we find is always a problem is how to talk about populations of people that have been historically marginalized, oppressed, and underserved. And one of the things we fall into is this practice of trying to define other people, right? And it's even more challenging when you're trying to define a population of people who've experienced systematic declothing, right? The stripping of their identity, whether it be their ethnic identity, their religious identity, or just simply how they define themselves and connect to their own heritage and connect to their own legacy as a human being. So one of the things we introduced was historically oppressed and other people's experiencing inequities. Historically oppressed peoples who were brought from Africa are defined as people who were brought from Africa and enslaved in America and indigenous First Nations. We're including within that definition, indigenous First Nations, any descendants of groups who trace their genealogy back to indigenous Mexicans, Aztecs, Mayans, and Incas, and whose lands were colonized by Europeans. When we say Europeans, we're meaning British, we meaning Spanish, we meaning Portuguese, right? We meaning French, right? Anyone that comes from the lands of Europe that came to America, Central, South, and North America and took people's lands and occupied these spaces, right? Those populations of people who have their lands taken and those populations of people that was brought over here as slaves have been historically oppressed, historically marginalized, and according to public health, because of the actual conditions that they're dealing with, they should be prioritized when it comes to building equity, when it comes to balancing out a long history of imbalance. But we're also not ignoring that other people have experienced inequities as well too. So you have the other people's experiencing inequities, which includes, right, women, which also is included within that population of Africans and indigenous populations, right? Muslims, immigrants, LGBTQ2I, and people with disabilities, et cetera, et cetera. We can go on and on. We know that there's a lot of people being done unfairly. But again, we're saying that there's a prioritization of those who have historically experienced that versus knowing when to support those who may be experiencing inequities in our society. We want to bring this language in because it's always a delicate conversation when talking about who should be supported when it comes to this notion of racial healing, right? Or this notion of racial justice or whatever term we want to use. I personally don't prefer the term race. I believe there's other ways to describe the crisis that we're dealing with. We know we live in a racialized society, so sometimes you have to use those terms. So again, Hopis, historically oppressed and other people's experiencing inequities. What has been the experience of those people? Real quickly, want to have a brief conversation. I'm not going to spend too much time with you. I would normally give a more thorough overview, but I want to give you some baseline in order for us to have a conversation about racial justice or racial healing. Next slide, Romana. So again, real quick, when you're looking at structural and social determinants of health, everyone wants to talk about social determinants. Years, maybe 5, 6, 7 years ago, social determinants wasn't a popular term, but now it's a very popular term and it looks like low-hanging fruit, right? But you can't talk about social determinants without talking about structural determinants. You can't talk about structural determinants unless you talk about the culture, right, of violence, the culture of oppression that's present inside of our society. That in America, Central, South, and North America, that begins with European colonialism, right? So we know European colonialism has its roots going all the way back to the 1400s, some say 1490, 1500s, however you look at it. But that was, again, those European countries that came over here. And for whatever reasons, because there's a lot of reasons why they came, when they got here, their intention was to survive by eliminating other people's ability to thrive, right? So their whole goal was, in order for us to be able to sustain here, we have to take from others. And they did that, and they did it very effectively. Within that, they also later came and began to initiate a process of bringing slaves from Africa, right, over into these lands and identified them as actual populations of people who can be worked, right, to the point of complete annihilation if they need to be. The individual would be worked even and treated less than the actual the dogs or the actual animals that they actually was required to take care of, right? And this was a mentality. It was justified by many different sources, right? Science was reinforcing it, religion was reinforcing it, the law was reinforcing it. So it was a very comprehensive effort. Although everybody didn't participate, it was a dominant theme, right? And that was a dominant theme for Africans as well as other indigenous populations inside of these lands. So again, let's just talk about real quickly the birth of the nation. In 1776, the United States of America, as we know it today, was established, right? That's pretty significant when you think about the Constitution, which was ratified in June 21st, 1788. In the first article in the second section, they had a conversation about slaves and anyone that wasn't European, specifically European males. And they wanted to understand how to really manage this question of actual taxation as it relates to populations. And what they determined was that, when it comes to slavery, these slaves wasn't considered completely human being. So in our society and in most societies, law is what's moral. What's legal is what's considered to be morally right. So they determined it was morally right to actually sustain the slave system and to also identify those slaves as not being completely human, right? 3/5 of a human being. That's really important to understand. We're talking about the psychosis of our society. Well, there was an opportunity to change that, right? People went to war, did a noble thing. America had, sons went to war with fathers, right? From different parts of the country, South and the North, to say, we don't want to participate in this anymore. And they shed a lot of blood not to participate in this. And when they had the opportunity to overcome the individuals that wanted to support the continuation of slavery, they missed the opportunity when they passed the amendment, the law, right, of ending slavery. Emancipation Proclamation was just a proclamation by the president, by Abraham Lincoln. But when the 13th Amendment was actually passed, there was a language that stated that slavery and indentured servitude in all its forms shall be abolished except for. Now, I always say, I don't care if they said except for someone with blue eyes or except for someone with big feet. The reality was that there was an exception to dehumanization, right? And they said that that exception was when one is duly convicted of a crime. So keep that exception in mind when you start talking about what began to take place right after the so-called end of slavery, right? And again, I'm going to give you a case study to the African American, but this particular case study can be pinpointed within indigenous populations, could be pinpointed with people that identify as being Hispanic or Latino. It can be pinpointed, across the board for populations because they all have a narrative. But I want to give you something really quick to really focus in on when we look at structural and social determinants and give a tangible example. So when slavery was supposed to end, but it didn't end, right, and they justified it, immediately you began to see this era within Reconstruction era, within 10 years, right, African Americans was able to thrive at a level that was unprecedented. They became politicians, they became business owners, they became educators, right? After going through what they went through for 300 something plus years of being considered less than human, not being able to read, not being able to lead themselves, they immediately began to thrive. They thrived so much that systems and organizations had to emerge, right, to be able to actually suppress that success. This was the emergence of KKK and various other entities in order to stop the success of African Americans, right, in that particular era. Will that continue all the way to the end of the actual 1800s, going into the 1900s, where whole cities have began to thrive, like in Wilmington, North Carolina, very prosperous African American led city, one of the actual most wealthiest cities in North Carolina. Individuals had to come in 1898 and literally initiate a 2-day long coup, killing people, murdering, making them hand over their homes, making them hand over their business. This happened all the way from the late 1900s, or early 1900s, going into like the 1920s, 1930s, where whole cities were being occupied and their wealth and their actual success was being undermined. Then we had lynching that took place, right, all the way up until 1940s, 1950s. So you had all this external type of oppression and attacks, this cultural violence being imposed upon this population, but still this population thrived, right? Up until the 1960s, where it reached the height, right, of visibility, where you start seeing movements across our country beginning to change and look at shifting how we think about our society in relation to people that was not European inside of America. 1960s had the Black, liberation movement. It had the Civil Rights movement. It had other type of movements, and it was a very, prosperous time inside of our history. Next slide, Ramona. Thank you. Now, what I want to take you is from the 1960s all the way up into the 1980s. And the reason why I want to give you this piece, because the 1980s is having a really deep impact in our society today. And what took place in the 1980s as it relates to structural and social determinants is because of Cold War politics, the end of World War II, there were some decisions being made to stop certain countries, specifically Nicaragua, from being successful in socialism inside of Central and South America, right? So Nicaragua was targeted as a threat to the United States geopolitical positionality. So they was willing to do anything to stop that society or that country from being successful. So one of the things they was willing to do was allow for crack cocaine, specifically cocaine, by the thousands of tons to be regenerated or to be trafficked inside of the United States of America. And it was trafficked within actual communities that was predominantly African-American and Latino communities. Within the African-American community, that trafficking of cocaine and crack produced this type of mega multi-million-dollar industry of violence and actual, decentralization and essentially self-inflicted war upon the community. African Americans developed gangs. They already had gangs, but those gangs at that particular time didn't have any economic incentive. The average person on the street was actually, selling maybe marijuana, right? Maybe robbing banks, but they didn't have an economic source, right? That shifted once cocaine was placed into those communities and kids had guns in their hands and had access to wealth, and people flocked to that particular culture because it looked at it as a way out. At the same time, right, that particular process was happening in the mid 1980s, the United States of America, while they knew that there was drugs being put into those communities, they initiated the actual second war on drug. The first one was in the 1970s, and they had the 1980s. Ramona, go to the next slide. Again, just real quick, those images up inside that slide right there is Ricky Ross, one of the gentlemen that was being trafficked, was doing the majority of the trafficking of those drugs. And this was the gentleman by the name of Gary Webb that actually got killed. They say he killed himself, but he was the one that disclosed the dark web, of activity that was happening with the CIA and the FBI and whatnot. He's one of my superheroes, true talk. Anyway, in the 1980s, right? While we know that crack cocaine was being put into our community, or cocaine was being put on the community, and this violence was escalating, right? They initiated their war on drugs. And inside this Kerry report that took place in 87 and 88, you can hear them saying that payments to drug traffickers by the U.S. State Department of Funds authorized by the Congress for humanitarian assistance to the Contras, in some cases after the traffickers have been indicted by federal law enforcement agencies on drug charges, and others while traffickers were under active investigation by them same agencies, right? So I just put that there so we don't be thinking this is some type of big, great conspiracy theory. This is nationally known information. What you want to look at is the graph over there. In the early 1980s, prison populations was an average of like maybe 300,000. By the end of the 1990s, those prison populations actually went from 300,000 to 1 million. If you keep looking, by the 1990s, when they defined us as actual super predators, right, because the prison population, well, because of the type of violent behavior we was involved in, right, you had another 10 years and those prison populations went from 1 million to 2 million, and then so forth. We had a 2.5, 2.8 million consistent flow. right? That's like a whole 2 generations of actual young people being funneled into prisons. Next slide, Romana. And again, I'm running through this really quick, and I'm probably already a little bit over time, but I want to make sure y'all get this point. In prisons are the most violent place in America, right? These young people, I got arrested at 17 years old, and I can tell you that when you go into the prisons, you understand a certain level of hand-to-hand combat and a certain level of martial escalated mentality, a martial mind, a military mind of how to survive that's unprecedented on American soil. So you put these individuals by the hundreds of thousands, millions into these prisons, the most violent place in America. 90% of them come home, and up until maybe like 10 years ago, the word rehabilitation wasn't even being identified. So crack cocaine produced it gang violence at an escalated rate. Gang violence then was coupled with the simultaneous attack by way of actual over policing and the war on drugs, which was a war on the people. Those populations of people then was put into prisons. Those prisons come home and do what? They interact with their families. They bring the trauma, they bring the violence, right? They create more instability inside the community. A lot of brilliant people come home too, but the majority come home and they bring their trauma and they bring the learned culture of interpersonal violence back to their community. Hence, in those environments, not only you have young people, but even the elderly people, because of toxic stress, they become more exposed and more vulnerable to mental health, because that's what toxic stress breaks down, as well as chronic disease, because toxic stress also breaks down the actual immune system and the central nervous system. So again, just giving the example, when you look today and you see what's happening inside of our communities, interpersonal violence, as I wrap, interpersonal violence, whether it be gang violence, domestic violence, child molestation, robbery, that's always been present. But in the African American community, as an example, it's never thrived, right? It's never thrived so disruptively as it's thriving today. Even when we had lynching and we was being treated as actual less than human, and we had whole cities being destroyed, you have no record of actual Black people killing and murdering and actually molesting Black people overwhelmingly. Since the mass incarceration and the culture of violence in those prisons coming home to our communities where they can't live anywhere because legally you can deny them rights of actual housing. They can't work most places because legally you can deny them rights of actual employment, get concentrated and placed inside these geographical locations. And this is where we see the community health worker being responsible for doing most of its work, whether it's within the African-American, Latino, indigenous populations, or other populations experiencing some form of inequity. So again, that's the context. If we're talking about racial healing, you got to actually make sure you understand the full context of what we're dealing with. It's something really deep inside of our system that needs to be transformed. And it's not inside just the actual laws. It's not just inside the systems. It's inside the human being. Romana.
We're going to now talk about the solution to this, which gets us into the policy. And so we're going to also connect how multiple forms of violence is connected to racial inequities. So before we begin, we wanted to give a shout out to the authors, contributors, and endorsers. Many of you have probably seen the authors, myself, Abdullah, Dr. Danny Ritchie, Dr. Cynthia Williams, Keela Marlin, Dr. Noel Wiggins. We have multiple contributors, including Angie Kuzma, who, as you all know, is a policy manager at NATRA and also one of the co-chairs of the APHA Policy Committee. I'm not going to read all the names. I'm sure you all can see them, but they were basically, we had more than 50% representation of CHWs and CHW allies across the country. Also, special acknowledgments went out to Betsy and Rafa Way from the CDC. APHA endorsements, we got quite a few from a number of sections, which is rare. This included maternal child health, public health social work, oral health, family violence prevention, women's caucus, men's caucus, and the law section. And external endorsements, these were organizations that endorsed this policy and took a risk before the policy got passed. CHASM, North Carolina Area Health Education Center, North Carolina CHW Association, Partners in Health, Common Indicators Project, and the University of Wisconsin Population Health Institute. NATRA will be putting out a press release with ourselves and APHA CHW section around January 20th once the policy is passed. And so I'm going to talk about this very briefly. This is a letter that was received and letting us know that we got a positive assessment, which is great. This is towards the end of it. We had a couple of negative assessments. We were able to turn that around. If any of you are interested in seeing the other policies and seeing our policy, we can drop in the link. And then we also have a link for the policy hearing, which is about 2 minutes, and the passcode as well, if you want to see that. And we're actually one of the first people in the hearing, so we're in the recording the first ones in the recording for C1. This is a process that we went through. A part of creating a policy that's equitable is having a process that's equitable. So we used a participatory process. We started back in January 2021, took a vote on what kind of policy we want to work on. We landed on this one. And you can see it was a really long process. Part of it being because it was a late breaker that didn't get accepted. Then we got a couple of negative assessments. Finally, we had a unanimous vote that passed. Our governing counselors were really great. Angeline and Maria, they were both there and they did a fabulous job. And it finally got passed in February 2022, or it got approved. And then in November 2022, there was a vote and a final approval took place at the governing council meeting. So a little bit of background, and I'm sorry, I'm going to go a little bit fast because I don't want to run out of time. But all of this is in the APHA policy that's going to come out, and we will, I believe the newsletter that Aurora and Natcher sent out has the link in there, and around January 1st, just check that link and it should be up there. So racism as a public health crisis was accepted in October 24, 2020. Violence as a public health issue was approved November 13, 2018. As of August 6, 2021, this number has grown to about 257 currently. 257 cities, counties, and other governmental leaders have declared racism as a public health crisis. However, our community health workers section of APHA identified a policy gap. That CHWs can help professionals comprehensively address inequities within their communities as a workforce across the country. They are lived and have been birthed out of inequities within their communities. And so our policy statement, we had a different title and we also had to change that, became known as a C1, a strategy to address racism and violence as public health priorities, community health workers advancing equity and violence prevention. Again, the problem statement, there's no clear strategy to address racism and public health crisis. So we felt like our section, the workforce that we advocate for, that we're a part of, could effectively do this in a comprehensive way across the country. And so we had 3 points. That was an overview. Number one, systemic racism and violence have been widely acknowledged as public health emergencies. However, we currently lack comprehensive strategies that address the underlying causes of these public health threats. CHWs are well suited and well placed to address these underlying causes and reduce violence and racism. To make an optimum contribution to addressing racism and violence, CHWs need to be trained, supported, and provided more opportunities through program development. And to break this down, this is the rationale for consideration. So you can see this is a socio-ecological model, which is the theoretical framework within the policy. It shows that CHWs can address structural and social determinants of health across the socio-ecological models. So first argument, racial inequities is a key root driver of poor health outcomes in communities. Next, one of the outcomes of these inequities is disproportionate exposure to multiple forms of violence. This becomes an exacerbator for existing social insecurities. CHWs have been engaged in building health equity by addressing underlying causes and were collectively birthed out of inequities within their communities. And actually the Aurora, the blog that she referred to that Denise did, is cited in our policy where we refer to that in order to support this statement. Lastly, CHWs can work effectively with other professionals to address systemic racism and multiple forms of violence. So we're not saying only CHWs can do this. We're saying they can support other professionals to do this in the field effectively. One of the oppositions we had was that they thought we were only lifting up CHWs not to work with other professionals. And that's not what we're saying. We're saying the work can be better and health outcomes, positive health outcomes can be reached with the help of CHWs in our communities. I'm going to pass it on to Abdullah for the history of CHWs.
So real quick, we just want to highlight a couple of things. First of all, we know that the whole notion of community health workers is like this natural response. It's like an organic type of immune system. Whenever there's harm being caused within a certain community, human beings naturally step up and be able to fill in gaps, right? So if you're dealing with slavery and you're dealing with colonization, if you're dealing with any form of oppression, whoever's oppressing is not concerned about the health and well-being of the people they're oppressing. So naturally, those individuals that's being oppressed have to naturally step up and begin to actually support each other when it comes to being sick, when it comes to pregnancy and birthing children, when it comes to what I'm saying, just trying to live a quality life under the actual pressure of what they're dealing with. So CHWs, or this concept of CHWs, has been around for a long time. But the US in North America started studying in the 1960s. They identified outreach worker programs, they studied Black Panther programs, they studied the civil rights movement, they studied actual programs within the Latino community, indigenous population community, and started noticing that in absence of them providing the services that they should be providing them, these populations were figuring it out on their own. And once they started studying them and trying to produce literature related to them, they identified that they had a particular resource that they wanted to take advantage of. They didn't call them CHWs. They had names that was different. At the time, they had community health lay workers, right? And then you have the community health representatives. When the US, decided to kind of start attacking the social justice organizations, when those programs shut down, you still have the concept that communities can provide services for themselves. Those professionals got integrated into health systems. The community health representatives became the more prominent type of health profession to build the community health worker profession at the time. They got integrated, right? Well, that was done in a way that was regulatory. They regulated them in a certain type of way. And our community health representatives did their best to kind of preserve and to actually keep what was authentic about the actual profession. But nonetheless, though, it wasn't until the 1980s, right, when a lot of Latinos or individuals that may identify as Latinos, but people coming from Central and South America migrated into the North, and those that was here began to show that we can do this on our own. We don't necessarily have to play to the rules of the actual health systems. We're going to actually work and we're going to provide services for our community. In many cases, because they was dealing with immigration issues, they couldn't integrate with the actual system, with the health systems or other type of, more structural type of entities. So they began to demonstrate really what it looks like when community assets are activated and can do for themselves. That shift the whole dynamics as it relates to how health systems and health professionals were interacting with quote unquote CHWs, or people that was identifying as such, promotores, health representatives. So then when that shift happened in the 1990s, right, you have the, where is it at, Ramana? I think we didn't highlight it. But in the 1990s, you have the National Community Health Worker Advisory Act that was passed. Bernie Sanders actually had passed it, but that created a kind of network of individuals. And this is where the community health worker term came up at, right? Because you had promoters, you had lay workers, you had the actual community health representatives, you had people that had many different titles. And it was under that particular debate that people said, okay, listen, we're going to pick this neutral term, right, called community health worker, right? But it's going to represent all of us while all of us still able to represent ourselves. So it's important us to know that whenever you say a community health worker, that's a term that was agreed upon to represent all the different other professions, promoters and other community health representatives, community health lay workers. They was present, they've been beating the drum, they've been establishing that particular front line, and it's important to note that. Later, APHA began to make a statement, the CHW section for self-determination, when we actually defined ourselves. 1994 Act. There you go. Thank you. And then we defined ourselves by actually identifying a very specific type of definition for CHWs. That was actually passed by the APHA CHW section. And then the National Association for Community Health Workers, right? An unprecedented national entity was founded, right, in 2019. And that brings us to 2022 when this particular policy is passed. Again, a lot happened in between those times. A lot of people did amazing work. But those are some spotlights to kind of show you the transitions, where we came from, what's been happening in between, and where we're potentially at now. And again, there's other amazing work that's happening outside of this policy right now. We're just highlighting that for the purpose of racial justice. Is this a community-based organization, evidence-based?
Yes, this is you.
So one of the evidence-based strategies that was highlighted to address violence was the STRIVE program, striving to reduce youth violence everywhere up out of Multnomah County. 2011 between 2016. Again, it was a CDC funded initiative. And this particular program was spotlighted because it was clearly co-led by community health workers. Dr. Noel Wiggins was a principal investigator, myself and a gentleman by the name of Dwight Myrick. We was at the forefront of the process from the beginning to the end. And the community health workers were able to exhibit their capacity to function through all levels of the sociological model. For instance, when it came to policy, right, CHWs participated in the countywide comprehensive gang assessment, and we also supported the elimination of the gang list inside Portland, Oregon, which was actually a huge victory for us. And community health workers using public health language was responsible for making that happen. On the organizational level, we adapted community health worker certification to actually address violence. We also trained other CHWs in the traditional community health worker curriculum, but we also adapted it not only for violence, but for the African American, and we supported that adaptation for indigenous populations as well too. The Latino population was already locked and solid because when they developed it, there was mostly the promotorial supporting Noel Wiggins to develop it. So we had to adapt it from that for everybody else. On an individual level, youth empowerment solutions, you'll learn more about that later on. We talk about the adaptation of the STRIVE model, but pretty much identifying young people to lead inside their communities. Very successful program. So again, this was spotlighted as an evidence-based strategy because it showed that without questions, that if you give CHWs the opportunity, they can demonstrate value at every level of the actual social ecology, from the systems policy all the way down to the community direct service and community-wide initiatives like health promotion and community organizing. So again, that's one of the evidence-based strategies, and there was other subsequent evidence-based strategies that was coupled with this main one, STRIVE.
So the other evidence-based strategy that we used was REACH, and this was used to support the racial equity work of community health workers. Now, community health workers have been doing racial equity work for a number of years. They were birthed out of that. They don't get recognized for that. So we had to pull from that. So REACH was between 2007 and 2012. I'm not going to read every bullet because we're running out of time. They demonstrated evidence of CHW contribution. So we also took it again across the socio-ecological model, the work that CHWs did. You can see some of the numbers and the improvements that happened. So emergency department visits were reduced by 50% on the organization community level. CHWs, integrated social determinants of health, resulted in an ROI of $1.46 for every dollar invested. And then we also talk about on the organization level, trainings that should be taking place. We did one racial equity workshop that Angie was also training in as well. And then also on the individual level, REACH CHWs provided interventions at an after-school program. So again, when the policy comes out, please refer to these evidence-based strategies and you'll have some more insight about it. So these are the action steps. There's a lot, and I don't think we have time to read through all of them. But some of the key points are making funding available to community-based organizations, those led by HOPEs, which Adila defined for you, looking at popular education, training and building CHW skills to address systemic racism and violence, lifting up the pre-APHA summit as an example, which was led by CASM, supported by NCAHEC, and hosted by the APHA section, make funding available to community-based organizations, especially by HOPEs and selected public agencies, to create programs that support CHWs to play a wide range of roles, including roles focused on addressing violence and promoting health equity across all levels of the SDN, make funding available to researchers and evaluators who have experience using community-based and community-based strategies, include CHWs as part of that from HOPE communities, provide funding that allows sufficient time for program evaluation and planning that is sustainable over the long term. Historically, CHW programs have depended almost exclusively on short-term grants. So look at braided payment, look at alternative payment models, moving away from fee-for-service and grant payments, collect consistent data about the process and outcomes of CHW programs. And again, there's some more information there, and also CHW Common Indicators Project is also identified as a resource for evaluation. And then we have some more. So APHA calls on state legislators to pass legislation providing funding to state health departments to take actions consistent with the above priorities. APHA calls on national and local associations and CHW employees to endorse CHW's trainings in interpersonal violence, systemic racism. External endorsements include the following. You all saw that on the first slide. That's actually when we go to next steps. That's part of what we're going to talk about. APHA calls on foundations and other funders to take action consistent with the above priorities and provide funding for organizations, especially those led by HOPEs with experience training, hiring, and retaining, and conducting research and evaluation with and about CHWs. APHA calls on colleges and universities that train other public professionals to include curricula and information about the historic role and potential of CHWs to contribute to eliminating health inequities by addressing structural racism and violence. And again, I'm not trying not to read all of it. And so we wanted to give an example of the work we've been doing in North Carolina as well as nationally. So nationally, CHWs have co-led and co-designed CHW Allies, the national workshop that we had in 2022, which Denise also attended, informed by RWJF dissertation work. And Southeast region, we did a training that was last year with Center for Community Health Alignment, funded by Johnson & Johnson for North Carolina and South Carolina CHWs. In the state, CHWs for COVID response and resilient communities. The CDC has been working on 3 components to train, deploy, and engage CHWs during COVID. NC-AHEC is implementing these trainings, and CASM has been co-designing racial equity and CHW culture trainings across the state, supervisor trainings, AMH trainings, Hopper Education, North Carolina Learning Collaborative, and been a part of the ESSO series. We're also working with the North Carolina AHEC, North Carolina CHW Association. Shout out to Honey, and she's here. Crosswalks with the SCN, and partnered this is partnered with the North Carolina CHW Association, led by the association, and also NC-AHEC, and then conducting listening sessions for the North Carolina CHW Association. Locally, work has been done in Dakota House, Cape Fear Region, the Racial and Health Equity Summit, and training CHWs in violence prevention. I'm going to hand it off to Abdullah, and then we have one more slide.
So real quick, so when you look at the STRIVE program as an evidence-based strategy, from the National Lit Review that was passed by the CDC, which I was able to help to support that particular effort, which validated CHWs and violence prevention, and then the actual Lit Review is the policy itself and STRIVE. The adaptation of the STRIVE program is taking place inside of the Cape Fear region, and recently just got scaled into Buncombe County, which is another area near Asheville in the northern regions of North Carolina. Just real quick, community-based public health response to violence, a comprehensive community-based public health informed strategy to prevent structural and interpersonal violence. What we're saying is this, and this is all based off the STRIVE program. All the programs come from it. It's just been scaled to say that what the CDC did, from the CDC to the health department into community organization, institutions, then into the community, we're doing from the community all the way back up. And what it is this: it's identifying community professionals, community health workers, that focus on violence prevention, that focus on addressing advocacy as it relates to inequities, and activating them from the spectrum of 18 years old all the way to 50 and a little bit over 50, anywhere within that spectrum of people with lived experience that are being hired as CHWs that have that lived experience, right? They're being trained and deployed in the community, right? In addition, we are identifying youth, young people, young leaders to understand the origins, impacts, and potential solutions of violence so they can become peer leaders amongst their actual peers to support their peers and thinking different about violence and how violence interact in their world, and also changing those norms. So you have the adult, you have the youth, then you have the built environment, crime prevention through environmental design, activating dormant assets in the community and using those spaces to actually build more connectivity in the community and make the actual community more activated as far as working together by using your built environment, right? Then you have CPRV or CBPR, right, which is the community-based participatory research, making sure the narrative of the community, so CHWs as researchers and youth as actually participating in participatory research, making sure the narrative of the community is visible and present and is influencing where dollars are going and where they shouldn't be going. Popular education, a pedagogy of transformation, a pedagogy of teaching and sharing, right, in order to mobilize community. That's the 5th evidence-based strategy. Then you have the multi-sector stakeholder coalition. We as a community, we can't do it by ourselves. So we need everybody at the table and address this problem that impacts us all collectively. And then the last one is being very clear. When we talk about racial healing or any type of healing, you can't heal a community by just making them feel, quote unquote, more connected and more like that butterfly feeling, right? That's not healing, right? To make me feel better and make me feel more connected, that's one thing. But you have to also build efficacy. You have to help them learn how to actually stop the harm from continuously happening. Again, community cohesion, collective efficacy, that's the main indicator. So again, that was a real quick, but CPRV is really a driving force when it comes to taking community assets, community language, crosswalking it with public health language, and then vice versa. Again, that's happening in the Cape Fear region and in Buncombe County.
I'm going to close it out with next steps. So if you're interested to externally endorse, we'll be sending out a poll. I think it's going to be around Thursday. We don't know which Thursday yet, but we're going to send out a poll. Please email us at admin@chasmnetwork.org if you need an official form or if you want information about policy meetings coming up from next month. Number 2, we're partnering with NATRA to submit the first press release nationally. That a template will be used. This template that we help create and gave to them will be used for following press releases. Again, come to the policy meetings or email us to find out more information. Number 3, part of the policy committee meetings will be gathering national leaders to mobilize on policy, led by the APHA CHW Section Policy Committee. One of those leaders has been Marcia Morales, who has been amazing. She's a community outreach worker from the University of Wisconsin Population Health Institute, and she mobilized a majority of the people in the state. It was absolutely amazing. Number 4, mobilization state to state. TASM is working on a policy and equity toolkit, and it'll include examples of CHW equity and violence prevention work. And then number 5, lastly, we will also archiving policies. We'll make updates in the future about CHW training taking place in health equity, racial equity, and violence prevention, and have supporting data outside of REACH and some of the other resources that you saw. So thank you so much for your time. I'm sorry we went a little bit over, but we have 9 minutes, I think, for questions. Sorry about that, Aurora.
No, no problem at all. Folks were, I don't know if folks were looking at the chat, but folks were really enjoying the presentation. I also want to say, especially while Abdullah was sort of giving the first part of presentation about really the history, that we actually had Abdullah and Ramana last spring give a more in-depth presentation, particularly around that history. So if folks are interested in that, I just dropped that link in the chat. And now we have a couple minutes left for any questions folks have. Please feel free to drop them in the chat or come off mute and ask your question.
Do you find that a lot of organizations, in order for us to get the statistics necessary for there to show efficacy, it sometimes is debilitating because you don't have the autonomy to do as much work as you could. Do you find that?
Yeah, so one of the things we're doing with the CPRV model from the community-based lens, right, is activating and training the community-based organizations and the CHWs to understand the value of research and to know how to use qualitative research, right, which they have access to because most communities don't want to share their narratives because they've been treated wrongly, but the community health workers got the trust. So if they can go into the community and say, hey, listen, if I can get what your perspective is, I can promise you that I'm going to advocate that this knowledge and information is used in an equitable manner. Then they go to the institutions that's kind of pushing out this quantitative focus type of data. And they say, hey, listen, you need this narrative to add more clarification to what you're doing, right? And those institutions then want to partner. And what's happening then is you're creating the self-reported experiences and the self-reported success that's happening inside the community and is being integrated into the reports that's actually being produced by larger institutions. And even though most institutions have been comfortable with quantitative data, right, it's way more competitive if they can get access to that qualitative. So community-based organizations and community health workers learn how to leverage their positionality. We're positioned in the community, we can get that. So again, that's why you have the community-based participatory research, and then Ramana with the work that she does is amazing in even training CHWs and how to be researchers more effectively, right?
Thank you.
Yeah, so thank you. You're welcome, Jesse. I wanted to follow up with that, exactly what Abdullah said. Part of it is that quantitative data is used, but you're not getting to the correct outcomes that you need to measure. And those measures are being so you want to measure what matters. And those measures are being determined by systems. And actually, Evan, who's on this call, she's doing a new initiative looking at evaluation, CHWs being trained as evaluators. That's been a key part of my work, and it's a part of CHWs as equity advocates. Is how do you get them trained as evaluators, as researchers, lift up lived experience on the process rather than just looking at quant hard data, because that experience is very relevant when it comes to racial inequities and violence in our communities.
Thank you. We should have time for at least one more question. I'm not seeing anything in the chat, but if folks might be typing away or if someone wants to come on the mic.
I have a question. Just thinking through, like, what is one thing that individuals that are in this space can do following today to kind of support the spread of awareness about this policy like, what, you know, I know there are lots of options, but I think it'd be great if we could share like 1 or 2 concrete things that folks can do next.
Ramona, I can follow up after you answer.
Yeah, what can people do? Is that what you said, Evan? I was responding to people in text. So yeah, so we actually talked about it in next steps. So this is part of some of what we're doing right now. So the next steps include press releases. So now that the first press release coming out will be led by NACHWA, partnering with ourselves and APHA CHW section. And then we'll be doing press releases by region and states. We'll be talking about that with different states within the policy committee or different organizations. CDC is interested. North Carolina has kind of started planning that. Evan and Honey and representatives from ORH and Partners in Health. Another piece is the toolkit that PASM is developing on how to implement this policy, what kind of framework should be used, and equity included within that. And we'll have case examples of what the work looks like for violence prevention and CHWs as equity advocates. And again, not everybody has to use that toolkit. Everybody is going to, you know, put their hands on this policy and have a different approach to it, and that's fine. But if you do want a little bit more insight on how to go about it, CASM is working on a toolkit for that. We're also going to mobilize leaders across the country, CHW allies and CHWs. APHA CHW committee has had great attendance so far, and hopefully it'll go up with this policy being accepted. So those were the next steps. We're going to talk about data, what data is being collected, how can we show this, how can we work together collectively to mobilize across the country to implement this policy. Hopefully that was helpful.
And I was it was excellent, Ramona. I was to add to as well. So there's 2 things, right? One is, so just in terms of like staying focused and what they can do when the press release come out, right? You're going to get a lot of instruction on what can be done. It becomes a template where you can actually share in your locales and across your state. And then it's also going to be information on how you can plug in. And if you're not choosing to plug in to be able to help like co-lead across the country, maybe you have a program or a model that you feel like the actual, you know, policy can help reinforce and support you getting funding, then at least plug in for the purpose of capacity building and learning the language that's been actually introduced. Because again, this language that's been introduced is coming from a community lens, but it's been endorsed at one of the highest levels of public health legitimacy, the oldest public health entity in the country, the largest public health entity in the country at its 150-year anniversary, right? You have to understand they actually approved this language, addressing structural violence, addressing structural determinants, addressing the connection between structural violence and structural determinants as it relates to social determinants, right? Language related to Hopis, all these things are things that they thoroughly like interrogated and questioned us about, right? We got a couple negative reviews. They really put us to the test to make sure we actually stood up to a certain standard that APHA was comfortable with. And we met that standard. Even the actual law section endorsed, right? You know what I'm saying? The actual policy, right? That's huge. So what I want to share with you guys in the last thought with 2 minutes left is this. Listen, outside of all that, the most important thing you can do, we're talking about racial healing, right? The most important thing each one of us can do is understand that there is a shift, a potential shift in our country, and things shift many directions. One time it shifts towards a direction that's not at our advantage. But right now, right, there's a shift that's at our advantage. We have something that's actually legitimizing some legitimate language and legitimizing a legitimate profession that's long overdue and being legitimized. Prep yourself, get courageous, right, in how you're thinking. Get courageous in how you're loving, which then translates into your actual behaviors in your workplace when you're talking about this. This is the time to spend more time researching and investigating and equipping yourself to be able to be that true advocate and be able to partner with anyone and everyone that's willing to work together to make this happen. This is that time. This policy is not the only thing that's happened. It's a lot of things that's happening in the universe right now. So my encouragement to you is grab a hold of the moment, right? And if you don't know where to plug in at, this policy is, this policy is definitely
a movement, right? Instead of a moment. So what we want to do is create a movement.
We have to make it a movement, right? Right now it's a moment, right? We have to make it a movement. And how we make it a movement is that individuals take the time to be diligent about what they're studying, how they're spending their time. And again, I'm gonna put this word back out there, man. This is the time to cultivate courage in how you're thinking and how we say that we're loving humanity. Right? That's what's going to be needed. And then pay attention to what's going to happen with the press release. Y'all can always reach out to us, reach out to NACHWA, APHA, wherever your networks is at, reach out to those people and say, hey, how do we get connected to these people that's leading this particular initiative so we can actually support it? I'll just leave it at that.
Thank you. Thank you, Abdullah and Romana. Thank you for this presentation, but also thank you for your leadership and your advocacy and for your partnership. We really appreciate you guys working with us, and for everyone here, thank you so much for coming and taking the time out of your day. I'm going to throw a link in the chat. It's a very quick survey to let us know how we did and how to improve the webinars and what else you'd like to see in this next year in 2023. Thank you all for participating in the chat. We love it, and for coming to our first annual national webinar for National Day for Racial Healing. You're going to be hearing much more about this soon. I'm going to be following up with all these links and the press release for everyone who registered. So you'll have at least 2 chances to feel that. But again, thank you so much for taking your time out. And we hope to see you all very soon. So thank you very much. Have a great day.